Hello, my name is Kathy Shalafor. I'm an ICM registrar here in Severn Deanery, and this is a short presentation on ARDS, or Acute Respiratory Distress Syndrome. ARDS is a significant problem within intensive care and can be life-threatening. It's a diffuse, acute inflammatory lung injury, affecting the alveolar to different degrees, causing increased pulmonary vascular permeability and non-cardiogenic pulmonary edema. This leads to reduced gas exchange, worsening arterial oxygenation, but the lungs also become stiff and less compliant and harder to ventilate. There are many causes of ARDS, and these can be considered either as a result of direct pulmonary injury or of a systemic insult. Of course, they may coexist within the same patient. Types of direct pulmonary injury causing ARDS include pneumonia, be it viral or bacterial, and COVID-19 was a significant cause of ARDS in our patients. Smoke inhalation, aspiration of gastric contents or other fluids, lung contusions in trauma, fat embolism which can occur during bone fractures and orthopedic procedures, near drowning, oxygen toxicity from prolonged exposure to high concentrations of inspired oxygen, and disseminated intravascular coagulopathy or other alveolar hemorrhage. Systemic insults which can lead to ARDS include inflammatory conditions such as pancreatitis or burns, sepsis which may not necessarily be of lung origin, and trauma which may not cause direct pulmonary injury. Other causes include hypovolemic shock, transfusion reactions, cardiopulmonary bypass, and abdominal compartment syndrome. ARDS was first defined in 1994 by the American and European Consensus Conference. In 2011, an expert panel further refined the definition, and this is known as the Berlin criteria. The Berlin criteria are used in the context of a known risk factor for ARDS and the application of a positive end expiratory pressure, or PEEP, of at least 5 centimetres of water. The first of the 4 criteria is timing. ARDS can be considered when symptoms occur within 1 week of a known clinical insult or new or worsening respiratory symptoms. On imaging, bilateral lung infiltrates should be seen that cannot be fully explained by effusions. This can be either on a chest X-ray or a CT. The origin of the edema should not be fully explained by cardiac failure or fluid overload, and in the absence of a known risk factor for ARDS, objective assessment in the form of an echocardiogram is needed to exclude cardiac failure. The final criteria is oxygenation, or the degree of oxygenation failure, and this is classified using the PF ratio. That is the relationship between the arterial pressure of oxygen and the fraction of inspired oxygen. Using milliliters of mercury, this is less than 300, but it also allows us to classify ARDS as mild, moderate or severe. Here you can see how the PF ratio is used to grade the severity of ARDS. Mild ARDS is considered a PF ratio between 200 and 300 millimeters of mercury, that is between 26.6 and 40 kilopascals. Moderate is between 100 and 200 millimeters of mercury, or between 13.3 and 26.6 kilopascals, and severe ARDS is considered a PF ratio of less than 100 or less than 13.3 kilopascals, and the mortality increases with the severity of the ARDS. This is an example of a chest X-ray, which is classical for ARDS, with diffuse, bilateral, patchy infiltrates. The pathophysiology of ARDS can be considered in several stages. After the initial pulmonary injury or systemic insult, an exudative phase begins. The alveolar capillary membrane is disrupted, inflammatory cells migrate to the lungs, and there is the formation of a high-protein exudate. Abnormal alveolar cells begin to proliferate, and the infiltration of fibroblasts leads to replacement of the alveoli with fibrotic tissue. If the condition doesn't prove fatal, the lungs may then enter an episode of resolution, where there is slow and often incomplete repair of the lungs and restoration of the normal lung architecture. These changes at the alveolar level have several clinical effects. The natural actions of surfactant are impaired, causing collapse of the alveoli. There is VQ mismatch, that is, the ventilation and perfusion of the lung, is imbalanced, causing hypoxemia. There is reduced compliance, by which we mean that for a given pressure, there is less volume achieved in ventilation. This is because of surfactant failure, collapse of the affected lung, reduced lung volumes, stiff, heavy, wet lungs, and fibrosis as the disease progresses. There is collapse and consolidation of the affected lung, increased work of breathing, and pulmonary hypertension can develop. The management of ARDS consists of several strategies, but one that is particularly important is lung protective ventilation, or LPV. The majority of patients with ARDS will need mechanical ventilation, but the use of improper ventilatory strategies can worsen the injury by causing a ventilator-induced lung injury. There are several types of ventilator-induced lung injury. They are principally barotrauma, caused by the application of inappropriately high pressures, volutrauma by the use of too large tidal volumes, and atellect trauma, which is a type of shearing trauma caused by the progressive recruitment and derecruitment, opening and closing of affected alveoli. Lung protective ventilation aims to minimise these types of trauma and prevent extension of the pulmonary injury. It was described by the ARDS network and consists of several components. The first of these is a high PEEP strategy, that is the application of a high positive end expiratory pressure to prevent alveolar collapse and derecruitment, and this minimises atellect trauma. The use of restrictive tidal volumes is advised, that is 6 mL per kilo of ideal body weight to reduce volutrauma. Low plateau pressures of less than 30 centimetres of waters are advised, and for patients with an escalating requirement for oxygen should have a matched escalation in their positive end expiratory pressure. The strategy also advises permissive hypercapnia, by which we mean the acceptance of a slightly higher than normal CO2, as long as there isn't excessive respiratory acidosis. This may not be possible in some patients, for example those with a brain injury, where low to normal CO2 is part of the neuroprotective strategy. To facilitate this form of mechanical ventilation, it's advised that patients should be deeply sedated and often paralysed to ensure complete control of ventilation. Another important component of the care of patients with ARDS is the use of prone ventilation. The PROCEIVA trial was a large multi-centred trial in 2013 that demonstrated a significant reduction in mortality in patients with severe ARDS when they were nursed in the prone position for periods of at least 16 hours. There are many physiological reasons why prone ventilation may be of benefit in ARDS, but a significant reason is that by repositioning the patient in the prone position, perfusion is shifted to the anterior portions of the lung, which tend to be relatively spared from the changes affecting the dependent alveoli. This technique is now used commonly, and you may well be part of a proning team during your time in intensive care. There are many other important areas of management in ARDS. Optimal nutrition should be aimed for, and we work with our dietitians to try and achieve this. Fluid management is also extremely important as we try to reduce the extravascular lung water. This is achieved by minimising infusions, a conservative fluid strategy, and by the use of diuretics. Pleural effusion should be drained where present, as they worsen collapse and consolidation. There is also a role for inhaled nitric oxide or prostacyclins. These are both pulmonary vasodilators and can work to improve VQ mismatch by improving pulmonary vasodilatation in the areas of lung that are best ventilated. And there may also be a role for steroids early on in the ARDS process to reduce that proliferative and exudative phase. As with many other disease states in intensive care, it is vital that while supporting the physiology, we also treat the underlying cause. In ARDS, this means recognising, identifying and treating the pulmonary injury or systemic insult that has caused the lung injury. For patients with worsening hypoxemia, despite all of the above measures, this may be an indication for a referral to an ECMO centre. ECMO is extracorporeal membrane oxygenation, whereby blood is drained from the patient pass through an oxygenator, and return to the body, essentially bypassing the need for functioning lungs. It is not without risks, and there are various criteria that need to be considered when an ECMO referral is made. You can learn more about this during your intensive care placements. I hope you can see that ARDS is a complex condition that can be extremely challenging to manage. It's associated with significant morbidity and mortality, with an average in-hospital mortality approaching 40%, though this can be higher in severe cases. Survivors may take many months to recover, and a certain proportion may never have full resolution and develop long-term fibrosis. Patients with ARDS have prolonged periods of mechanical ventilation with sedation and paralysis, and long stays on intensive care. This is then associated with delirium, critical care weakness, and we know can affect how patients recover psychologically from their stay in critical care. Many thanks for listening. I hope this has been a helpful overview of ARDS and that you'll find it useful during your forthcoming intensive care placements.